Okay, welcome back, everyone. Midwest CEPAC members, we're going to go into the voting questions now, and we will rely somewhat on on Jason and Dimitri to center us on what it is we need to be looking at. The first question, if you'll advance the slide. The patient population for all these questions is adults with transthyretin amyloid cardiomyopathy. Jason, would you like to review us, or look, I'll read the question and then you can review us on where in the presentation you spoke about this. So for adults with ATTR-CM, is the current evidence adequate to demonstrate that the net health benefit of tafamidis is greater than that of no disease-specific treatment?
I'll take it from here.
Yeah, Jason, if you can point to the evidence summary.
Oh, sure. Yeah. For the sake of the CEPAC, I'll just kind of reference the evidence summary. So for tafamidis, we gave a B+ ranking. I know there's been a lot of discussion today about the B+ versus A. Just to reiterate what Dr. Rind has already said, this is a strong level of confidence in our assessment of the evidence. And then the specific data come from the ATTR-ACT trial, which appear that the main results appear in table 7 on page 6. So you can see a hazard ratio for mortality of 0.7. So it's mortality reducing in addition to other important clinical endpoints like cardiovascular related hospitalizations, the 6-minute walk test, and patient symptoms as reported for the Kansas City Cardiomyopathy questionnaire. So it is true. I mean, this is a mortality reducing drug, which is relatively unusual in the cardiovascular space these days.
Thank you. Are there any questions about that? Kurt?
Yeah, and just for clarification's sake, we're talking about all NYHA classifications. So this is irregardless of 1 versus 2 versus 3 versus 4. Is that right?
Yeah, I mean, I think the trial excluded class 4, so that is worth noting, but I don't think there's anything specific to the question that's meant to refer to a specific NYHA class.
Okay, thank you.
Any other questions? Okay, everyone cast their votes. I think we're looking for 15 voters. We have one more person to capture.
I'm wondering if Alan, are you on and able to vote?
I don't see him on. Yeah, I do.
Because he was traveling.
My apologies. The hospice nurse just called, and so I was talking to them, and I just came back over. So I took the call, and I didn't know where we were in the process before we came off break. So I apologize.
No problem at all. Do you want us to wait for you to vote, or do you not want to vote?
No, please go ahead. I'm going to join the vote at this point, and I apologize to everyone. Should I not vote at all, or if I can get into the voting, should I jump in now, or should I just step out since I missed the first few?
Why don't we have you vote on questions going forward from here?
Okay. Thank you.
So questions going forward after this one, is that what you're saying, David?
I think that makes sense. Yeah, I just
Okay.
I don't want Alan to have to rush
Yeah.
in. Yeah.
For sure. Okay, so I think this question's complete then. Okay, next slide. For adults with ATTR-CM, is the current evidence adequate to demonstrate that the net health benefit of acoramidis is greater than that compared to no disease-specific treatment?
Yeah, so again, for the panel, we assigned a B+ rating, again, a very strong rating that reflected the results of the ATTRibute-CM trial, the primary results of which are in table 8 in the evidence summary. So you can see a trend towards increased survival, though there was this nuance as to the statistical approach in terms of showing that they've not really shown that there was a decrease in mortality. But it's that trend is concordant with all sorts of other things getting better, cardiovascular hospitalization, 6-minute walk time, KCCQ, symptom assessment, patient-reported outcomes through KCCQ. So we had thought there was compelling evidence of this treatment working.
Are there other questions? Okay, everyone cast your votes. Okay. Next question, please. For adults with ATTR-CM, is the current evidence adequate to demonstrate the net health benefit of vutrisiran is greater than that of compared to no disease-specific treatment?
So the primary results to inform this come from the HELIOS-B trial, the results of which were published very recently, a few weeks ago. It's in table 9 of your evidence summary. And so keep in mind in this trial, this is a comparison of vutrisiran versus placebo, but people in both groups are on tafamidis, about 40% were. So critically important, vutrisiran compared to placebo seems to have reduced mortality as well as a series of other sort of positive effects. And we thought it was really remarkable that occurred in a less sick population. Conceptually, that should be really hard to demonstrate, but so it was all the more remarkable that there was a decrease in mortality. And important for this question, with no disease-specific treatment, there's no differences in this trial between those who are also getting tafamidis versus those who are getting no tafamidis. So we thought that it was exceptionally compelling evidence that this was an effective treatment.
Okay, everyone cast your votes. Okay, I'm not sure where the 15th vote is. Has everyone who's listened voted?
Jill, I think it's okay to move ahead.
Okay,
Yes,
thank you.
I think that's fine. Thank you.
Okay. Okay, question 4. For adults with ATTR-CM, is the current evidence adequate to demonstrate that the net health benefit of vutrisiran added to tafamidis is greater than that of tafamidis alone?
So this rating we also gave an A. So the evidence is still from the HELIOS-B trial. Again, just to be explicit about this, HELIOS-B was a randomization of vutrisiran versus no vutrisiran. But again, both individuals in both arms, and 40% were on, roughly 40% were on tafamidis. there was no there wasn't a statistically significant difference in mortality, but there's no evidence of heterogeneous treatment effects. There was no reason to believe, that this improvement was in any way blunted by tafamidis, which is to say it strongly suggests that there may be an additive effect of vutrisiran on top of tafamidis. The data are in the same table that I referenced for the last question, which is table 9.
David Rand.
I was hoping that our clinical experts could comment on what they think about this, since this is obviously a big deal at the moment.
I have to say, I'm not sure. When I think about the pathophysiology, if you silence enough TTR, do you really need to then stabilize it? And we know there's about an 80% silencing with vutrisiran. Number one. Number two, I know that they emphasized in the manuscript that there's no heterogeneity of treatment effect, but they really focused on the monotherapy arm and saying if you got vutrisiran alone, you did well. I don't think they really dived as deep as I would have liked them to do on the combination therapy arm. I really think we do not know if it's going to be beneficial clinically to patients.
And that applies both to adding vutrisiran to tafamidis,
Oh, I'm
as
sorry.
well as adding
I meant
tafamidis
adding.
to.
I think both alone, I'm convinced are beneficial, but adding, I have no idea, and I just
In
don't
either
understand.
direction. Okay, thanks.
Correct.
Yeah, I agree with Michelle. I mean, absence of heterogeneity doesn't mean proof of efficacy. And, the trial is small, 655 people, of which you can do the math, 200 and some odd. So we're talking 120 people in each arm who are on combination or not. Wasn't balanced per se on tafamidis use. So it's going to require, in my opinion, a much, much, much larger end to determine whether or not a combination therapy is effective.
Thank you for that. That's super helpful. Eric, I saw your hand up earlier. Do you have a question?
Question was answered by their responses. Thank you.
Okay, are there other questions for the experts? Okay, then everyone cast your vote. Okay. Next question, is the currently available evidence adequate to distinguish the net health benefit among the interventions when used as monotherapy? Tafamidis, acoramidis, and vutrisiran.
So yeah, the key issue here is that there's no trial. There's no trial that compare any of these agents against one another. And we're really very cautious about over-interpreting, comparing hazard ratios between trials with different populations. The populations are totally different between all of these trials. I can't reference this in the evidence summary, but you remember my slides with the bar chart with the mortality changing between the trials. There's also a table that's pertinent to this in the evidence summary. Table 6 shows that the NYHA class 3 individuals, of the sickest ones, was 32% in ATTR ACT, 17% in ATTRibute-CM, and 10% in HELIOS-B. These are totally different populations. I think it's very difficult to say. There are arguments the other way, and I'm happy to try to summarize them, and I'd also love to hear some of the clinical experts, but that's sort of our thoughts.
Thank you. Are there other questions? Okay, everyone cast your vote.
I think Matt wants to say something.
Okay, Matt.
No, I was just going to reiterate, I think you're right on target. I mean, the trials are very different. And to be honest, if you look at the confidence intervals, because the trials are small around the hazard ratios, they're all overlapping. I mean, I think what you'll see in trials is as the patients get less sick, there'll be less of an effect on mortality. And to be honest, a bigger effect anticipated on hospitalizations. But that's intuitive, given what we're talking about. So I agree completely. There isn't, in my opinion, any evidence at this point. And unfortunately, us clinicians are going to be in this very confused place of trying to pick which agent to give which patient in what order. And I have no idea how we'll do that personally.
Okay. Thank you. Okay. Okay, so for the benefits beyond health and special ethical priorities, we would like to tap into the patient experts, or the patients that were gracious enough to come today. So to help inform judgments of overall long-term value for money, please indicate your level of agreement with the following statement. So here's the first item. There is substantial unmet need despite currently available treatments. So would either patient advocate be willing to comment before we vote? Regarding unmet needs, despite having heart failure treatments and tafamidis already on the market, are there still unmet needs?
My take is medically the needs of these drugs are working. The unmet need, I mean, I always lean towards talking about the need to diagnose people once people are diagnosed. These drugs that we have now are available and are proving to be effective. Is that the type of information that you're looking for? Okay.
Yes.
Yep.
Are there does anybody else have a comment?
I would just say that listening carefully to my patients, I think there is still a large clinical unmet need. These, if you look at beyond, mortality and morbidity, there are still residual risks in both of those. And, if you look at measures of quality of life and functional capacity, which are very important to patients, there's still declines despite treatment. Things are not stable, at least in most of the trials. And so I think patients that I speak to all the time would want more. There is a big unmet residual risk to them from their perspective.
Based on that, are you saying that even patients who are on tafamidis, there are still unmet needs that you're seeing?
Correct.
Okay. Eric.
Spent the earlier years of my career, focusing on heart failure. And, so it's really wonderful to see this case come before us. But I would say in general, patients with heart failure have unmet needs. And it's in part because of the progressive declining nature of this condition. And it's like many other progressive, conditions, the unmet needs are still there. Clearly, we have a couple interventions here that are slowing that down and maintaining or slowing down reductions in quality of life, which is where I would probably focus my attention on this particular question as opposed to just mortality. So I'll just tell you, I think that there is unmet need, but I think it belongs to the category of heart failure patients in total and not necessarily this particular diagnosis. But I really appreciate the comment from our patient partner who highlighted the importance of keen diagnosis as a particular need for this particular subtype, if you want to call it that. So I just wanted to share my thoughts on that. Thanks.
Thank you. Michelle.
One of the most striking unmet needs that's already been touched on is the fact that the treatments we have don't reverse disease. They slow progression. And if we contrast it with other forms of heart failure, guideline-directed medical therapy does make people feel better. Some hypertrophic cardiomyopathy therapies do make people feel better. So it's a striking conversation about managing expectations and an unmet need that we cannot really help you feel better. We just hope we can slow down feeling worse.
Gregory.
Yes, I just wanted to underscore that having a drug with a novel mechanism of action that is quite different from tafamidis, I think is a very valuable addition. This problem is not going to be solved with one mechanism of action.
Thank you. Milton.
Yes. When I was diagnosed with the hereditary amyloidosis, I was already at basically like stage 4. Back of my heart was totally stiff. So there was really no medication or anything they could give to me at that time because of my condition. I had limited, they really didn't see a lot of symptoms because I was basically fit and everything. So they basically put a ICD in my heart, but there was no medication they could give me for 2 years for it because the amyloidosis was there. My heart was failing and it was affecting my liver at the time as well. So I don't know if there was a medication at that time that they could have given to me, but there was no medication that was given to me. And they basically the hospital I was at was very familiar with amyloidosis, et cetera, et cetera. But for 2 years, it just led to a point in which it just got such a decline that I had to have the transplant versus any medication. So that's actually my treatment now, the transplant itself, and it's dormant. So the medication for the 2-year period was a problem for me because they couldn't come up or there was none that they could give to me because of the condition of the heart.
Thank you. That's super helpful to hear. Thank you.
Okay.
Anybody else have a statement or a question? Okay, cast your votes. Okay. Question 7. This condition is of substantial relevance for people from a racial or ethnic group that have not been equitably served by the healthcare system. Would either patient partner today like to comment on that?
Yeah, so I do work with the Amyloidosis Speakers Bureau, so I go out and speak, and I've had the opportunity to speak at facilities that represent various diverse ethnicities. I can tell you that and I think everyone in here knows this, but the big impact or the big concern is for the Black American community, people of West African descent. And I think there's a huge unmet need there, not only for the treatment, but back to my previous comment on the ability to get diagnosed. So, and Milton may be able to speak to this add on here. The trick is to get people in the communities, in these ethnic communities, to get diagnosed, to get to the hospitals, to get to the treatment centers, and to find out that they actually have this disease. I also spoke down in Texas to a group that represents the Latino American community, and they expressed similar concern. Milton, I don't know if you want to add to that.
Yeah, it's a good point that you're making there. One thing about my community is Black community is even my own kids. I like to start there. It's a personal share more or less, but it's very critical, and this is why I'm involved. because I went through what everything I went through and I've explained it to it. I'm out here getting a lot of knowledge trying to make sure that they themselves would, get themselves checked out and understand a little bit about the process about amyloidosis and everything else. And it's very, very difficult within my community to get that, to get the message there. But the outreach back, I think it's just as critical too in terms of amyloidosis. Now it seems to be becoming more of a, I would say, I like to call a grocery store word that you can use or conversation. Whereas before, when I was first diagnosed in 2011, when I said it, what is that? Where's it come from? I really had to explain it to every single person. So I think the outreach back is just as important as and I'm just as crucial of it as the participation that we have from those that need to get diagnosed in our community, or to know the actual test to run, or the places to go to get the test run, to have the resources to get the test run. It just snowballs in their effect. So I just want to share that point because I think there's a little bit on both sides with that. But I do think in terms of the Black community, that we're a little bit left to the side there when it comes to the amyloidosis. I got to be honest about that totally.
Thank you, Milton. Matthew.
Yeah, this is excellent comments, and I would say this is a unique condition that has a huge predisposition to ethnic and racial disparities. V122I, the variant we talked about, as we heard, is almost exclusively in individuals of West African ancestry, who, as we heard, are either Black or Caribbean Hispanic, and the disease progresses faster in that population. Genetic testing is not something that's embraced by that community typically. We have pretty good data at our center that family cascade testing is done and executed in less than 10% of individuals who carry the V122I variant, and more than 80% of individuals who carry the ALA60 variant are individuals who are Irish. So there's inaccessibility and inequities in genetic testing. Where African Americans live in the United States, there are what we call amyloid deserts. There aren't expert centers. They're centered in areas so they don't have as good access to care, and that leads to, as we heard, later diagnosis and worse outcomes. And then I do have a concern about these wonderful therapies, but accessing them, so is not the easiest in the world. Most clinical cardiologists don't want to be bothered by trying to go through the pre-certification process, which, given their cost, is quite high. And quite alarmingly, at our center, which has, I think, the resources of a research pharmacy and lots of staff who can help people get onboarded, the process for a patient to access therapy is highly dependent upon where you live, like the area deprivation index. And that's not because the people in the most deprived areas are actually paying. They're not paying for the drug. It's the people in the richer areas that are paying. So it has nothing to do with cost. It's due to complexity of trying to navigate the process of pre-certification, and that leads to a disparity. So it's unequivocal in this disease that there's a huge health disparity, in my opinion.
Can you go on? Can you comment further on the pre-certification? Does a prescriber have to sign up for something like a REMS or something to prescribe this drug? I mean, what pre-certification are you talking about?
So you have to meet the criteria of the diagnosis, and then there is a certification process. Unfortunately, by many insurers, especially if you need to get drug at a lower cost, and so the sponsor has something called Vindalink. That's the trade name for the drug, and accessing that and filling out the appropriate paperwork is difficult for patients who have low medical education and so forth. And as a result, there are delays that, at least in our experience, are 3 times as long in patients who live in areas where, again, they don't end up paying for the drug compared to people who do pay for the drug, and they get it within a week or two, where other people could take months. So there's disparities in access to care, disparities in diagnosis, disparities in access to genetic testing. And then once you're diagnosed, it takes longer to get the drug. And that's just total reality, and something that we as a healthcare system need to focus a lot more on.
Thank you. Milton.
Yeah, I like just say also on my mother's side, my grandmother, 3 of my uncles, 2 of my aunts, they died from what they used to call old folks disease. So that lineage along with now my nieces and nephews, some of them also now have heart issues and also have pacemakers. So they just died, some of them back there, because they did not have in hospital any care, any knowledge of it. And they were basically left to fend for themselves. I'm blessed that when I first got diagnosed, that my primary care doctor was a cardiologist and he knew about amyloidosis and he picked it up real quick. He told me immediately if he had not known about amyloidosis, to know the test to run, to look into, to at least verify that I had amyloidosis, some sort of amyloid, that I would have been walking down the street and just died, because there's no test that you just come in for daily, at randomly, or annually to check to see if you have it. It's all about the family history. So I was blessed with that part of it, and he directed me to one of the hospitals to go to that would open it up. So I wanted to see how they connected with that. Thank you.
Thank you. Eric.
I'm just wondering if, the relevance for people from racial or ethnic groups that have not been equitably served in this particular case, right, is a function of the rareness of this particular condition or the difficulty of diagnosis. And that is related, I think maybe as Matthew alluded to, a more difficult navigation of the healthcare system for folks from rural or lower income areas, because subspecialty services and the diagnostic tools that they have are just more difficult to access. And so I'm kind of rethinking the way I was thinking about this particular issue, not so much from an epidemiological point of view, but from the difficulty of making the diagnosis. And without a diagnosis, the access to these treatments is not possible, right? And I think I've also gained an appreciation for, in our study of this particular condition, that it may not be as rare as people thought it was, but it's considered rare because because our diagnostic tools were so inept in the last decade. So I don't know, just my thinking on this, kind of rethinking this, not from like an epidemiological disease burden point of view, but from a slightly different angle that I don't ordinarily look at these particular questions in previous cases.
Very good points. Thank you. Matthew.
I just wanted to follow up on Eric's comments. I mean, I think disparities exist in medicine and in rare diseases where there's inadequate diagnosis. It's only, exacerbated. Just to be clear, there are 1.5 million allele carriers of the V122I variant in the United States. It's nowhere near a rare phenomenon. What is the penetrance of disease? Probably higher than we believe, and has an age dependent. So I think we have a lot of, in that regard, work to do. And I do think there are certain structural things that I've encountered that really impact on this, to your point about rural communities and lack of access. I can't do a telehealth visit legally unless I'm licensed in another state, which seems crazy to me. I often tell my institution, too bad, I'm doing it anyway. Because the bottom line is, if someone doesn't get a diagnosis, then they don't get cared for. And that's a huge problem for rare diseases where there's not expertise in various communities. Genetic testing, while we have communities that don't want to embrace it, genetic counselors in various states are not legally allowed, despite doing the counseling, to order the test. I don't know why. They have to wait for a clinician, potentially, who may be engaged or not, to order the test. And I can go on and on and on about the multitude of barriers that exist in our healthcare system that put people of color in disadvantaged circumstances, which is really a tragedy.
Very interesting. Okay, any other questions? Then for question 7, everyone cast your votes. Okay, we may only have 14 this vote. Anybody need more time? Okay. I think that's the end of it. 14 people. Okay, agree or strongly agree. Very good. Okay. The next questions are about the specific treatments. And the first one is the TTR stabilizers are likely to produce substantial improvement in caregivers' quality of life and or the ability to pursue their own education, work, and family life. Could either of the patient partners comment on caregivers in this question in any way?
Yeah, I can comment.
Okay.
Yeah. Once again, when it first happened diagnosed, my sister, she was a nurse, and two of my family members are nurses or in the healthcare field. And once again, they had no knowledge of what I was going through at the time. So they were basically going through and learning at the same time I was. So it was very, very difficult for me for the whole 2-year period. Also, there was transportation back and forth from Connecticut because my wife at the time had to work full time. So it was pretty much a burden on her because I had the ICD in my heart, stage 4, and they didn't know if I was just going to drop dead. So in terms of the caregiver side, being my wife, basically, it was a tremendous amount of stress put on her for that 2-year period, looking and seeing what I was going through and being a part of something that was basically unknown, because people know about cancer, people know about, certain diseases, but amyloidosis, it was something that we was just learning on the fly. So for 2 years, I'm thankful that she's hung in there with me. She did what she did in my family, but if it was not for the caregivers sharing their love and their support for me during a very tragic time to me, which was basically shocking to me because I had never been sick like that. I've always been able to take care of myself and everything. So I give just as much to people. I give a great deal of credit to my caregivers and the bedside nursing, but the caregivers overall, it's a great deal of stress that I believe when I look at them and see what they did. Thank you.
Thank you.
Yeah, I'd like to add to what Milton said. So I've got the T60 Irish variant, and I was diagnosed after probably 6 to 7 years of symptoms building in, and the disease was, I guess you'd say, and I think I heard this terminology earlier, that it was starting to wind up, to progress more rapidly. So when at the time that I was diagnosed in early 2019, I was in very poor physical condition, and in fact, spent 3 weeks at the hospital in Boston trying to stabilize things for me, and it was an incredible burden on my family, and as well as nobody in my family had ever heard of the disease before. So it was shocking to everybody, and that was a very trying situation for myself, my siblings, my wife, and whatnot. But I will tell you, I started the treatment, and I take it's now vutrisiran. I was on patisiran, so I take the silencer combined with I also take diflunisal with it. But it absolutely unequivocally halted the progression of my disease. And if you look at the clinical data, echo, all that, when I was diagnosed, and look at it now, there's in fact perhaps slight improvement in some of that data, but certainly not degraded. So what I'm getting at is now fast forward 5 years, and my wife is my caregiver, and she likes to tell people she doesn't really have to do much for me anymore other than put up with my little aches and quirks that I have. Every day can be different. And if you talk to amyloidosis patients, one day I could be out in the backyard trying to help do yard work and whatnot. The next day I have to lie around the couch and watch TV all day. So she says it's just a nuisance for her, but I know that she does a lot more for me than I fully realize. But back to Milton's point, at the time of diagnosis, it was from a caregiver standpoint, it was a tremendous burden on many people in my family. And I think this is a typical story that you hear from other patients as well.
Okay, thank you.
Yep.
Any other comments? Brad?
I'll make one real quick, and this is one where we actually have empirical data, on the quality of life, and pretty uniformly points to this. So it's as I answer this question, I'm not going to have to make any subjective gut checks. I feel like there's pretty good data on this one.
Thank you. Milton?
Yeah, I just wanted to say my variant is the VA122IA. I don't know if I said that earlier. Just want to make sure.
Okay, thank you. Matthew?
Yeah, I mean, I think the comments made by the patients are very elegant, and it's my clinical experience that caregiver burden is exceedingly high and obviously very, very difficult for family members and loved ones, especially as the disease progresses, and it's a huge burden on people. The other aspect, just to touch upon, is financial toxicity. There's a huge anxiety about accessing these medicines and continuing to access them on a year-to-year basis. So this is around the time of year, October, November, December, where people have to recertify. And, we have nearly 1,000 people at our center on drug without the support of, pharmacists and other folks ensuring that people get continued access. It would be a morass. So the financial toxicity data looks similar, if not worse, than people who have advanced malignancies, so you have a perspective.
Okay, thank you. Everyone cast your votes. Okay. Next question is acoramidis, I keep saying it wrong, offers a substantial opportunity to improve access to effective treatment by means of its mechanism of action or method of delivery. David, would you like to tell us more about this question?
So this is sort of an odd use of this question because we weren't going to get at this any other way, and I wanted to give the experts a chance to talk to this. We have a stabilizer, acoramidis, that is different from tafamidis and has a different target spot and a different amount of stabilization. And anytime a new therapy comes along with a new mechanism of action, there's potentially some benefit to that. But I wanted to give the experts at least a chance as we looked at this question, which is usually intended for something else as we vote, to say whether they think that acoramidis's different mechanism of action for stabilization is important.
If you're asking me, I don't think we know. So acoramidis mimics what's called the T119M super stabilizing variant. So biologically, if you have a variant in TTR that causes the protein to fall apart, Jeff Kelly, back in 2003, who invented tafamidis in his lab, discovered that the presence of a mutation that causes the protein to fall apart could lead to no phenotype in people who have this variant T119M. And while tafamidis binds in what's called the dimer-dimer interface, you're correct, acoramidis binds in a different spot. And at least the test tube stuff suggests it's potentially a better stabilizer. Whether that's going to translate into clinical differences to be determined. I've been impressed with both agents, to be honest, and it's just going to require a lot more data to know.
Thank you. Any other questions? Kurt?
Yeah, so these are both oral medications. Tafamidis is given once a day. Acoramidis is given twice a day. I always get a little nervous when you start increasing the frequency per day, but twice a day is usually okay to do. So for me, I'm having a tough time, I guess, distinguishing between the two.
I think you raise a good point, but I can tell you adherence to these medicines is, as you can imagine, astronomically high. Patients almost never, ever, ever miss a dose. It's amazing to me. In part, probably because of its difficulty accessing it and its cost. But I don't know that will, and again, one's dosed twice a day because of, bioavailability and so forth. So.
Thank you. Anything else? Any other questions? Okay, everyone cast your votes. Okay. Now we'll get to the long-term value for money. I think we'll have one question. The question is, given the available evidence on comparative clinical effectiveness and incremental cost effectiveness, and considering benefits beyond health and special ethical priorities, what is the long-term value for money of tafamidis compared to no disease-specific treatment at its current pricing? So before you vote, let's talk to Aaron about where would review for us where you reviewed this for us.
Sure. So if you look in the evidence summary, if you look at tables 9 and 10, that will give you the base case results. And then you can see in table 12 different scenarios that we look at.
Thank you. Aaron Carroll. You're muted.
Yep, I said sorry, that was a mistake.
Thank
I was
you.
trying to click over to the other thing. Sorry.
And just because it's been so long since we've had a price on a drug that we were voting on, to remind people that ICER thinks that, somewhere between $100,000 and $150,000 per quality or equal value life year is a threshold beyond which you start losing more health than you're getting health. And this is many, many times that. So these, despite tafamidis being a great drug, its cost effectiveness is much higher than typical thresholds that are used.
Okay, any other comments? Okay, then cast your votes. Anybody else want to vote? There's one more we're waiting on. Okay, we may not get it, so. Yay, we got it. Okay. Okay. So at this point, we're going to break for about 20 minutes and we'll resume at 2 p.m. Thank you.